Hi, Fola. How are ya? Good. Uh, one more day of weird temperature, remote things. What was that? I think it's to be honest, I don't even look today. I just know it's supposed to be warmer than yesterday. So,
Yeah, when I
and
when I woke
my
up
te
this morning, it's like 8 degrees. 8.
wow. Oh my gosh.
Yeah.
And you
First,
did I hear you work overnights? Is that
yeah,
correct? Every
yes.
single night?
It's not every single night. It's only on weekend. I'm free on the weekends.
But you work every like Monday through Friday
Yes,
overnight.
weekdays.
Oh
Yeah.
my God. Holy moly.
Yeah.
So, yeah, you're really traveling. What time do you go in?
10 o'clock.
And then
10,
what time's your shift over? 6?
6. It's just 8 hours shift.
Oh my God. Yeah, you're getting the brunt of the coldest temperatures there.
Yeah. Very cool.
Wow. Um, all right. Well, let's take a look at pneumonia today and again, kind of just I'll try to pick through some things that I think are important, but also just anything that you want to ask, you know, to reiterate. I'm happy to do so. Um, okay, so remember, pneumonia is a part of the lower respiratory tract lecture, but you don't need to review the other two forms, bronchitis or bronchiolitis. So you can skip, you can skip through those and um, you know, it's the largest section, but at least you can tailor a little bit here. So first thing that I think is key, and not that I specifically think that you have issues, but just to reset things, we do want to label our pneumonia as one of three types: community acquired, hospital acquired, or ventilator acquired. Um, for the most part, hospital acquired, so ventilator is actually a form of hospital acquired pneumonia because it is a pneumonia that patients get during a hospitalization. The only thing different is that they have a breathing tube, and so that makes them because they have a foreign body going into their lungs, it makes them even more susceptible to, to pneumonia. But the pathogens, the bacteria and other microbes that cause hospital acquired pneumonia are pretty much the same for both of these. But there is a big difference in bugs that cause CAP versus bugs that cause HAP. So we do want to get a little bit of a grounding on, what bugs belong under each of those categories. Okay, each of those types.
Mhm.
Does that make sense?
Yes.
Okay. So let's kind of just look at that for a second. So with community acquired pneumonia, these are the most common causative organisms. So I know yesterday, remember we talked about this because this was one of the questions, but both viruses, so respiratory viruses are the number one cause, right? Number one etiology of community acquired pneumonia. Um, the number one bacterial cause, though, is Streptococcus pneumoniae. Um, and so, really, these are together the top two. The orange ones, though, are the ones to kind of be familiar with. Um, sorry, I'm about to sneeze.
Yes.
Thank you. Um, But so wanting to look at, recognize any of these four in orange as being very common. Yesterday, I think you had asked to make sure that we reiterate like what gram negatives and gram positives and help to differentiate those. So let's go through that now. So Streptococcus pneumoniae, do you know if that's a gram positive, a gram negative, or an atypical? Or
Negative.
let's do all four. Gram positive, gram negative, atypical, or anaerobe, because anaerobes are also like a unique group. So you said gram negative, is that what I just heard?
Yes.
Okay, so all strep species, and there are a lot, all strep species are gram positives. Okay. Um, to me it's easier to remember the gram positives because there aren't that many of them. But it's staph, so staphylococcus, streptococcus, and enterococcus. Those three genuses are all gram positives. Okay. So that might help. So if it's not one of those, it's either gram positive or atypical, basically. Um, do you remember mycoplasma pneumonia? So what
Uh,
mycoplasma is?
that is atypical.
Yeah. So that is, like you said, that's an atypical, and the other two are chlamydia and legionella. But mycoplasma is the most common atypical, and you've probably heard this like winter season. Have you heard a lot of news about walking pneumonia? Like there's something that we call walking pneumonia, because people do okay. People kind of like try to fight it, and they try to like plow through, their day to day, because it doesn't make them super super sick, but eventually a lot of times they wind up getting sick, and it's like a nickname that we give to mycoplasma pneumoniae. So this right now, mycoplasma is very like this season, for whatever reason, it's been really bad. Um, and then the last of the top four is Haemophilus influenza. So what do you think that leaves us with?
That should be aerobic.
Well, all of these are aerobics. But it's not anaerobic. So we don't really point out what is aerobic, because if it's aerobic, we still classify it by grandpa, like all the other things. And there's no anaerobes that like regularly cause pneumonia. So none of these are anaerobic. So none of these are bacteria that live in situations without oxygen. So what I guess that only leaves us with one other. So it's not gram positive, it's not atypical, it's not anaerobic.
Negative.
So it's gram negative. Okay, so in our top four, we have viruses in general, respiratory viruses. So these are things, and just to be clear, these are things like influenza, RSV, um, metapneumovirus. There's a lot of those. It's up higher in the slides if you want to take a look at that. But these are the common viral respiratory pathogens. But we have viruses, we have a gram-positive bacteria, we have an atypical bacteria, and we have a gram-negative bacteria. Okay, so basically what that tells us is our guidelines that give us empiric treatment strategies for CAP are going to have to cover all of those bugs. Okay, so that's what we're aiming to, to cover. And that helps us understand why the, the guideline recommended drugs are what they are. So these are the key coverage there. Okay.
Yeah.
Um, okay. Any questions about that?
No question.
Okay. The next thing that I wanted to touch on, because it was on the assessment again, was curb 65, but curb 65 is an example of a tool that is used to help to determine how severe the patient's community acquired pneumonia is. Um, and again, depending on how sick they are, um, you know, clinicians need to determine whether or not they can be treated as an outpatient, should be hospitalized on a regular medical floor, or if they should be hospitalized in an ICU. Okay. And so these three slides are all examples of different clinical tools that are used to help to determine severity. Um, the the IDSA tool really just it mainly determines who needs ICU. So it doesn't really talk about all three treatment type like locations. But it is used to determine basically if an ICU is needed. And so you do not need to memorize this. But what it is showing is that there are two major criteria, multiple minor criteria. And if the patient has even just one of the major criteria, they need to go to the ICU. Or if they have three or more minor criteria, they need to go to the ICU. Okay, so for example, if they were on a mechanical ventilator or they're intubated with a breathing tube, that is a major criteria. So that alone, it like dictates that they need the ICU. If they don't, if they're not in septic shock, or if they are not on a mechanical ventilator, but they do have three of these criteria on the right side, then they also need ICU. So let's, for example, um, they have a respiratory rate of 35. They have a BUN of 30, and they have an altered mental status. So that meets three of those criteria, and then therefore they should also be hospitalized in an ICU setting. Okay, so again, this tool really just identifies ICU from non-ICU, ICU essentially. The other two tools have guidance as to all three. So outpatient, inpatient floor, or ICU. So the PSI, this one has a bunch of parameters. So again, we didn't really focus. You definitely don't need to memorize this or anything. But you for each of these bullet points, if if that was present in the patient, you would add that number of points to their score. And when their total score is added up, you use this table to essentially gauge what their mortality risk is and what the recommended site of care is. But it's very tedious because you have to go through every single parameter. You might remember doing this in an in-class activity.
Yes, I
Yeah.
remember.
So remember, like it took a long time. You need a lot of labs, you need a lot of information about the patient. So sometimes this is just not feasible. But it is a validated tool. So I did want to introduce it. Um, the easiest tool to use and the one that that we actually seem to use more in practice because it is so easy is the Curb 65. Um, so this is the one that I've, in the objectives, um, you were asked to be able to, know the Curb 65 parameters and apply it. Um, so sorry. Um, so the as I mentioned yesterday, the Curb and 65, it's like essentially an acronym. These are the 5 parameters: confusion, urea, respiratory rate, blood pressure, and age over 65. Um, and then this is the care pathway. So if they score a 0, they they can be treated as an outpatient. They are not they are not very sick. 1 or 2 requires admission to floor, and 3 to 5 would be ICU. Um, so it's primarily just memorization, but does like the concept make sense to you? Because these are all signs of basically organ organ damage. Confusion is a sign of issues, with the brain. Um, Urea or uremia is a sign of issues with the kidneys. Respiratory rate is a sign of issues, from the lungs. Blood pressure is a sign of issue with circulation in general and the heart. And then age is just that, older patients, especially when, 65 is a common marker of kind of crossing that bridge to, you know, the geriatric population. They are just at greater risk in general. So does this scoring tool make sense and how it's applied?
Yes.
Okay, good. Um, all right. So then, the guidelines have essentially 3 tables in terms of treatment that matches up whether they should be treated outpatient, treated inpatient, or treated ICU. So these are the the treatment algorithms for those respective populations. Um, so if patients are able to just, they see their doctor, they get a prescription, but they never are hospitalized, um, what what antibiotic they should receive is based on essentially whether they have other chronic medical conditions. So healthy patients who, don't have heart disease, lung disease, whatever, liver disease, etc. they can be treated with a relatively simple regimen, a one-drug regimen. Most patients are going to be treated with either a combination of a beta-lactam, so all of these are beta-lactams, plus either azithromycin or doxycycline. And so, again, to reiterate why we need a combination therapy here. So our beta-lactams cover, going back to our bugs, our beta-lactams cover streptococcus, and they cover Haemophilus and some of these other bugs down here, but they do not cover atypicals. Okay, so they're not treating the mycoplasma, they're not treating chlamydia, or they're not treating Legionella. So in order to get that coverage, you need to add one of these two drugs, azithromycin or doxycycline, because they cover atypical pathogens. Okay. And there is a single drug treatment though, which is using what we call a respiratory fluoroquinolone. There The quinolone that is missing from these is ciprofloxacin. If you might remember that, that's also a fluoroquinolone, but it's not considered a respiratory fluoroquinolone, because it does not. There's a lot of strep pneumo resistance to cipro. So the only two that are eligible are levofloxacin or moxifloxacin. And the reason that you don't need to add anything to a quinolone is because quinolones also cover atypicals, but they all, as well as strep pneumo, Haemophilus, etc. Okay, so all of those bugs on that common pathogen slide are covered by the quinolones. But if you remember, fluoroquinolones have a lot of side effects. Do you remember any of the side effects of fluoroquinolones?
Um, High toxicity.
I Not commonly. Here, let me actually pull up it might help to just if I pull up the like a drug monograph and you actually just see it like on LexiComp. Um, do you prefer LexiComp or Micromedics when you look things up?
I use add out to lexicon.
Either,
Yeah.
okay. So let me share here. Let's type in levofloxacin. And okay, so looking at like warnings, precautions, and things like that. So um oops, oh, my mouth is not working to read here. Okay. Some of the things we see here are tendon rupture, which actually that one has uh, black box warning for tendon rupture, QTC prolongation, aortic dissection, and then some other side effects, dizziness, restlessness, other CNS effects, glucose changes, risk for C. diff infection, um, peripheral neuropathy, so forth and so on. So there are, like you can see, there are, and all of these are considered to be significant. So they carry a lot of safety concerns. So even though they are first line, we often will use the combination of the beta-lactam and azithromycin or doxycycline, because those are generally safer than the fluoroquinolones. Okay. And then you can kind of look at how how the outpatient regimen compares to the inpatient regimen. So for the most part, it's the same options. The main difference is that the beta-lactams are now IV instead of oral. Okay, so these are inpatient, so hospitalized, but non-severe, meaning not needing an ICU. So the same type of options, but primarily the difference is that they are being given IV. Okay. And so these are beta-lactams that are only available IV. In hospitalized patients, though, the other thing is that you have to make a determination of whether they also need MRSA coverage or possibly Pseudomonas coverage. And that gets a little tricky. But what we talked about is the main risk factor for these drug-resistant pathogens are if they were hospitalized or received IV antibiotics in the past 90 days, or have been infected with MRSA or Pseudomonas before. So in those cases, you would have to kind of deviate from the standard regimen, and select from either add MRSA coverage or choose a beta-lactam that also covers Pseudomonas. Does that make sense?
Yes.
Okay. So basically, as an example, let's say I get really sick and I am admitted to the hospital, with community acquired pneumonia. I haven't had any, history of hospitalizations. Like, I'm kind of out of the blue hospitalized. I'm going to get probably a regimen of ceftriaxone and azithromycin, because the ceftriaxone is kind of the most commonly used. So I would get ceftriaxone and azithromycin. I would not need this or one of these. But let's say my mom, she had some IV antibiotics given to her a few weeks ago over the holidays, for something unrelated. It wasn't pneumonia, but if, let's say, she gets pneumonia, goes into the hospital, because she's had IV antibiotic exposure, so she's more susceptible to resistance. What she would get is probably one of these beta-lactams. So let's say cefepime, azithromycin, and then she would probably also get vancomycin because she has risk factors for these drug-resistant pathogens. So we still need a beta-lactam. We're just picking our beta-lactam from here. We still need azithromycin, so we're still going to give her that. But then she also needs MRSA coverage, so we're going to add one of these two drugs. That makes sense?
So that means she's going to have one from the standard and one from the MRSA.
Yeah, it is. It's a little confusion. So what so in place of these beta lactams, we're going to pick a beta lactam over. So all of these are also beta lactams. So instead of these, we're going to use one of these. We're still going to add azithromycin because we still need atypical coverage for atypical bacteria. And then adding a third drug for MRSA. So either vancomycin or linezolid.
So adding a third drug, making three, right?
So yeah, so if somebody received IV antibiotics within 90 days, they would be on a 3-drug regimen.
Okay.
Yeah. And then lastly, the severe inpatient. So these are our hospitalized patients. You don't need, you don't need to memorize this table or anything. But the key here is that in the ICU, everybody is getting at least 2 drugs. Even if they're given a fluoroquinolone, it's in combination with another with the beta lactam. So in the ICU, patients with severe CAP, they need at least 2, and they may need more if they also need MRSA coverage. Okay. All right. So that's well, I guess just to end things with duration, um, the minimum duration of therapy for patients with community-acquired pneumonia is 5 days. But it's usually no longer than 7. So it's usually a 5 to 7 day course, depending on how quickly they respond and how stable they are medically. Kind of switching gears over to hospital and ventilator acquired pneumonia. Again, these are, they're called hospital acquired because that is where the patient got sick. And we know that there are just a lot of dangerous bacteria, kind of lurking in the hospital because so many patients are sick and things can ultimately get spread. There's a lot of equipment and things like that of course should be sterile and whatnot. It's just sometimes things get transmitted. So these are again, patients who get pneumonia while hospitalized for something else. Okay. Here are the most common causes of HAP. So how many of these are the same as the community acquired bugs?
Two,
Which ones look the same?
the staphylococcus and the Klebsiella pneumoniae. I'm not
So
sure of the
so close. That's okay. Let me switch back real quick. Um, so yes to Staph aureus, that is still on the list of CAP, but that's the only one that overlaps. So with HAP, it's a very different group of pathogens that need to need are of concern, basically. Okay. So the drug regimens look very different. And the most common cause being Pseudomonas. So Pseudomonas wasn't even on our right, was not on the list of common causes of CAP. So that tells you that our empiric regimens are going to look a lot different because we have different drugs that we need to, different bugs that we need to cover for CAP. Um, so this is essentially it gets there's a lot going on in the table, but essentially this is the table that is followed to select um, treatment for hospital acquired pneumonia. Um, to be able to use this table, essentially, you it's asking that you have a sort of a gauge of what their risk of mortality is. And I said I would never ask you that because that really is a physician level assessment. But as pharmacists, we should be able to know, um, like if they do have the risk of MRSA, and we should try to find information as to whether or not they received IV antibiotics in the past 90 days. Um, so you really just find the column that meets the situation of the patient. So this is not at high risk of mortality and no risk of MRSA. You just pick one of these drugs. So um, all of the antibiotics in the top in this section of the table, they all treat Pseudomonas because that's our number one target. Okay. So they definitely need to be treated with something that treats Pseudomonas, um, like piperacillin tazobactam or cefepime. Okay. Um, if they have a risk of MRSA, then you add a drug that treats MRSA to to one of these. And then if you know that the patient has a high risk of mortality or has received recent IV antibiotics, then you actually pick 3 drugs, 2 out of here and 1 that covers MRSA. So does that make sense? So it's basically 1 drug, 2 drugs, 3 drugs, depending on what their criteria is. And I would be very, again, you don't need to determine what their risk of mortality is. So I would, tell you if they had a MRSA risk or if they received IV antibiotics.
I have a question.
Sure.
How do you recognize a patient that is in the risk of MRSA? Is it after the test, the culture test? How do we know?
So there are different um these are some of them here. Um, if they one definite thing is if they've had it in the past, like if they've been infected with MRSA in the past,
So
and you don't need to.
is it from their medical history that we can know that?
um yes, well, as long
Okay.
as you have an